Hello, everybody. I am going to tackle the structure and function of the respiratory system. Christine will be joining us in just a little bit. So, the respiratory system, how do we get oxygen in and carbon dioxide out? And how do we exchange it with the pulmonary system so then it can be delivered to the rest of the body? Um, so we have our learning objective here, and you have your study sheets also available, the study guides. So the first quick anatomy review, the upper respiratory system, nose and mouth. How do we get air from the environment down into our lungs? Upper respiratory starts nose and mouth and ends at the epiglottis. That's that flap that covers the trachea so that when we swallow food, it goes into our stomach, or if that doesn't close, then it's going to end up in our lungs. And I think you can remember us talking about aspiration pneumonia. That's a problem with that epiglottis not sealing off the lungs when we're trying to swallow something, either food or drink. So the entire respiratory tract is covered with a mucous membrane called the respiratory epithelium that helps moisten and protect the tissues. Now, that substance can become irritated either because of infection, smoke, pollutants, and it produces more mucus. That we'll discuss more later in the diseases portion of it. So air enters the body through the nose or mouth into the nasal and oral cavity, and that nasal cavity is divided by the nasal septum. That creates your right versus left sides. And it also contains olfactory neurons that tell us what we're smelling. And air will move posteriorly into the nasopharynx. The pharyngeal tonsils and or adenoids are located in the nasopharynx. Then it moves into the oropharynx, and then the laryngopharynx. That's what sits above the larynx or the voice box. Inferior to that aspect of the pharynx, air will continue into the trachea, food will enter the esophagus and move on to the GI system. The epiglottis, again, that flap that covers the trachea when we swallow to prevent food from entering the lower respiratory system. And airway resistance increases as you ascend that pharynx. The passages become narrower and narrower. So the resistance of that airway is also greater in supine than in sitting, and difficulty with breathing when you're laying in supine is called orthopnea. Very common for our patients, especially when there's a lot of weight on their chest to do so. When someone has orthopnea and they choose to sleep in a recliner rather than bed, now these kind of people are going to be at high risk for skin breakdown, but also postural abnormalities with that as well. The lower respiratory system includes the trachea, or that's the windpipe. That's the beginning of it. The trachea bifurcates or splits into left and right bronchi. That trachea has a rigid cartilaginous ring around them, much like if you think of a vacuum cleaner hose, that thicker substance to help keep it open. And they are lined with mucous membranes and have cilia, or little hair-like projections that sweep dust and foreign particles out of the airway. There's also neural receptors in the epithelium that can trigger cough reflex in response to these irritants. So the bronchi branch out just like a tree would, or a root system. And that's why it's called a bronchial tree, as it resembles that type of appearance. The branches of the bronchi become smaller and smaller until they're called bronchioles. Those are really small sections. And at the end are the terminal sacs, or alveoli. The alveoli are stretchy and expand, and that's actually, the alveoli is what's going to be the functional unit of the lungs. That's what's going to transfer gas between the lungs and the circulatory system. The alveoli exchange those gases, again, carbon dioxide out of the body, oxygen into the body, through the pulmonary capillaries. So the pulmonary capillaries bring deoxygenated blood into the lungs. The alveoli bring the oxygen, they trade off, and then that exchange of gas happens, and then the oxygenated lung goes back to the blood goes back to the heart. And there's a picture depicting the cross sections of that alveoli. So if we look at that alveoli, they basically look like bundles of grapes. And you can see kind of in this picture here where the pulmonary capillaries are surrounding that ball of the alveoli. The alveoli is spherical, and there's clumps of them. Again, it gives that great bunches of grapes appearance. That sphere helps with surface area. So the more surface area, the more blood supply can lay on top of it, and the more gas can be exchanged. So you could see how if there's excess mucus in this cross section, how that would narrow that airway, and then that would limit that gas exchange. So someone who has pneumonia or mucus in their lungs, that's going to narrow this airway, and it's going to make it harder to bring good air in and bad gases out. Some lung anatomy for us. The right lung has 3 lobes. The left lung has 2. The metastadium is that space in between the 2 lungs, right in this area. That's where the heart likes to rest, right there. But also the aorta, esophagus all sitting there. The left lobes are just the upper and lower lobe. The right lobe is upper, middle, and lower lobe as well. And there's also a bunch of segments to it that I don't believe we're going to get into deep today, but some textbooks and some nursing charts that you guys might be looking at might talk about different segments. There is a double layer of tissue called pleura, a pleural layer and a visceral layer. I'm sorry, the visceral layer of the pleura covers the lung space, and the parietal pleura covers that thoracic cavity. So the pleural cavity is in the space in between those 2 layers. There is a fluid called surfactant in that pleural space, and that helps lubricate the tissues, helps it make sure it can slide over one another when it expands and contracts, and reducing that friction as we breathe in and out. That space is airtight and also has a negative pressure, so that as the volume of the chest cavity increases, it's going to help pull those lungs and increase the space in the lungs. That way more gas can go into it. At the base of the chest is the diaphragm. That's the big functioning muscle of our muscles of inspiration and expiration. So when the diaphragm contracts, it actually gets pulled down, almost like an upside down umbrella or an inverted umbrella. And now that mechanism is going to create space in these lungs, and the lungs are going to be pulling more air into it as we breathe. There are other muscles that we'll talk about in just a minute as well, but the diaphragm is the big muscle of inspiration. So there are 2 systems for circulation in the body: the pulmonary system, which we'll look at here, and the systemic system, which runs throughout the rest of the body. So what this picture is trying to show us is the blue deoxygenated, sometimes called unoxygenated blood, enters the right atrium. Well, the blood is collected from the body. It goes into the right atrium of the heart. Then it goes to the right ventricle. Then it goes into the pulmonary artery and into the pulmonary capillaries. The pulmonary capillaries then exchange carbon dioxide and oxygen in that alveoli in the lungs. The blood then travels to the pulmonary vein, left atrium, left ventricle, and then from the left ventricle it goes to the rest of the body. So that's the mechanisms of where the blood is going in the heart and in the lungs, and it's that constant exchange from heart to lung, heart to lung, heart to lung, and exchanging all those gases. So the muscles of respiration, one, we already talked about, the diaphragm. The diaphragm is very efficient for breathing. It contracts, creates that negative pressure, and then it draws air in. When it relaxes, it returns to its normal resting place just below the lungs. So it's really easy because it conserve energy as we do it, as we use the diaphragm. When people don't breathe with their diaphragm, either because they don't know how, or maybe there's something wrong where they cannot, that becomes less efficient and more energy taxing just to breathe. The diaphragm is controlled by the phrenic nerve, which is innervated by C3 through C5 and the autonomic nervous system. So if you remember in our neurology injuries in the spinal cord, the higher up on the cervical spine you go, the more problems because of the muscles of respiration. This is exactly it because of that diaphragm. We also have intercostal muscles that increase the volume of the chest. They're in between the ribs. They can be affected by some spinal cord injuries as well. They're innervated segmentally T1 through T12. Now, exhaling is normally passive. So the diaphragm contracts, creates a negative pressure, brings the air in. Once the diaphragm relaxes, that air gets expelled out. Sometimes you need a forceful expiration. When we go into our next on the diseases portion, we'll talk about some testing that we can do with forced expiration. But sometimes when you're blowing out a birthday cake, blowing up a balloon, things like that, then you might need that forceful expiration where the abdominal muscles will contract. Now, we also have accessory muscles that can be used. A good therapist will observe our patients and look at these accessory muscles. If we know there is a cardiopulmonary or respiratory problem, we will examine these accessory muscles of inspiration. These are sternocleidomastoid, serratus anterior. So if I see a patient with gigantic hypertrophy of their SCMs and they're on oxygen, I know that, boy, they are having a lot of trouble breathing. I know that they've been having that problem a while because that SCM is trying to increase the amount of volume in the chest, therefore create more of that negative pressure, not allowing more air in. And the serratus anterior, I think we've all used at some point. So Christine's a runner. I am not. Although we had a race last week and I smoked her. I sprinted. She said go, and I smoked her. Now, I didn't realize we were running more than 100 feet. She kept going after that. So after my 100 feet of run, what do we do when we're all tired? What do? We put our hands on our knees. Why do our hands on our knees for that? Well, because we're using our secondary or accessory muscles of inspiration, like the serratus anterior. So we're stabilizing the scapula, and now we're using the serratus anterior to pull on our ribs to create that action. So pulmonary function is going to require tissue compliance. That means the flexibility of the tissue. They have to be able to expand and contract and expand and contract. Not only the big structures like the lungs and all of the ribs around it as well, but also the individual tissue. We need those alveoli to be flexible. We need the chest wall to be flexible. So all of the tissue that gets incorporated into this needs to happen. We want a clear airway, any resistance in the air, like we talked about with the mucus, just preventing that airflow. That's going to be an issue. We need chest movement to happen. So we need the ribs to expand and be able to fill up that area. The amount of air being able to move in and out is dependent on the ability of the chest cavity to increase that volume. So increased in the anterior posterior dimension through thoracic extension and sternum extension, or increased in lateral thoracic. So that's filling up. That's my lateral ribs being able to move out to the side. Diffusion is ability for the gases to be exchanged in the alveoli capillary membranes. So again, as the capillaries lay it right on top of that alveoli, we need that gas exchange to take place. Sometimes that can be interfered with fibrosis fluid. Edema can cause, so it's taking up space. That edema is taking up space where that's no longer, that gas exchange cannot happening. Concentration of gases will also alter our ability to exchange those gases. And then we also need oxygen to be able to bind to hemoglobin. So that's what has to happen. So the oxygen has to be able to attach to the red blood cells and the hemoglobin to be able to be carried throughout the rest of the body. Here's a picture of some of those things we were just talking about, how that the blood supply is wrapped around those alveolar sacs, and then how in this picture toward the right, how that alveolus, we have a high concentration of oxygen, low of carbon dioxide. In the deoxygenated blood, we have low oxygen, high carbon dioxide, and the two are going to try to equal each other. That's why that happens there. And then we also, lastly, just the nervous system component to it. So it's controlled by the autonomic nervous system. So it is something we don't have to think about. So it's relied on receptor sites throughout the body, chemoreceptors monitoring constantly how much carbon dioxide, how much oxygen, and what is the pH of the blood. So it'll be able to modulate our rate of respiration based on that. So there's also voluntary control. So if you're diving underwater, you have the ability to hold your breath if you needed to. So that's just a quick review of the structure and function of the respiratory system. Christine and I will talk about diseases next.